So today I'm going to talk about shoulder pain and the diagnostics and the ultrasound interventions. And to be very, very truthful, when we say shoulder ultrasound, I found somewhere in the periphery, I am very happy that you kept all these topics very, very practical for the pain physicians and how ultrasound can really benefit, and I think it's a must tool for all good pain physicians to have it in their office settings and even in their procedure rooms. You can really do a radiation free, a cost effective procedure, and you can really look at the dynamic part of it. That's the most, and evocative provocative part of it, and you can do the procedure in real time, and that's the most important thing. And then you have the structures visible, and you can really look, you're not going through any major vessel structure or viscous. This is very, very important. Yes, most important it is give you accuracy and all, but most important for us is the efficacy. We have to be efficacious in a procedure and give a pain-free patient at the end of the day. What are different differentials which are looking at the anterolateral shoulder pain? All I'm going to cover the shoulder as a whole, because it's very, very important to look the shoulder as a totality, because they all are connected structures. So we're looking at the rotator cuff tear, the subacromial impingement syndromes, and I don't always call subacromial because sometimes it is a coracoacromial ligament impingement syndrome. So I'm going to discuss that in a few slides later. And then the glenohumeral joint arthritis, adhesive capsulitis, and the bicep tendinosis, very, very common problem. Don't miss on this. And then we have some calcific tendinitis in a chronic phase, and it is very, very amenable to treatment. So look at this. And then acromial AC joint syndrome arthritis. Then you have labral tears and some cervical conditions and other things. We're going to talk that later. This is very, very important slide from theoretical point of view, although I kept less of the theory. And this is about what are the lateral rotators, the infraspinatus and teres minor, and the abductors is the supraspinatus muscle, and the medial rotators you see subscap and teres minor. These are the lateral medial rotators. And these are important muscles, because when you're talking about the action, you're going to do clinical examination and you're going to ask the history. So everything is going to be very, very clear. With the history and clinical examination, you really know most of the diagnosis. Ultrasound is to confirm and to go for the procedure further on. For a patient who has got a shoulder pain, for rotator cuff tears, we are doing a DD now. We have a pain in the night, pain over the head, when reaching over the head. Weakness may be there along with that, and we call it drop arm sign. And then maybe some history of injury also. In impingement syndrome, which is very common entity, and there's a pain at night, especially when reach over the head, and there's a repetitive, because there is a repetitive motion and movement, so there has been a pain there. And mostly with the profession like, racket players and the bowling players, they have this pain. And then maybe a weakness over a period of time. It's a very nasty pain, night pain. It wakes you up in the night and patient finds difficult to sleep again. But it is again one of those things which has got 100% relief, and I am one of those patients who injected oneself and got 100% relief. Then you have the shoulder osteoarthritis, which is pain all the times, and there's maybe loss of motion because of disuse atrophy, and there is a slow onset. It is insidious slow onset, and there may be crepitus positive, and mostly this is an older age problem. Same with the frozen shoulder, pain at all the time is the loss of motion, especially with external rotation. To tell you, frozen shoulder is more of an autoimmune kind of disorder which can come even after diabetes, MI, or stroke. So these things to be have looked at, and this is the end stage of all shoulder disease. You have frozen shoulder. The three phases: the freezing, frozen, and then resolution phase. And one should really look at which phase one is. Yes, with treatment you can really shorten those phases. The important test which is to be seen, there's huge battery of tests and very useful. I would like each and everyone to learn these and know this, and especially one or two I'll mention for supraspinatus. This is empty can test or Jot test, important. Same way you can differentiate from the impingement syndrome, which is knee test and Hawkins test, very important. And rotator cuff tear, you have the drop palm test which is there, and one should really know, and this is important. We have a good ultrasound pictorial images, so we have so many pictures. Be ready for a flight. And this is about the long head of biceps. I'm going to talk, because I'm going to talk shoulder. We start from there. This is protocol one should always follow. Don't jump just right to the pain point, see through and through, because there will be associated problems or multifactorial problems. And if you look at the MRI report, you see so many things together. This is how you look at the short head, and you put the arm in the lap in the supination, and then you see. This is what you're going to see. You're going to see the lesser tuberosity, greater tuberosity. There's the bicep tendon. You look at the tendon texture, size, the vascularity part of it, and then you're looking at the Doppler part of it, and then you see it's angry or how, or it may be absent or present, maybe it is black. Always remember this is anisotropy because tendon turns and rotates over the shoulder. So you may find it missed when you as soon as the correct perpendicular, the anisotropy is corrected. Remember there is some vessel here. This is ascending circumflex humeral artery, and you have to be wary of when you're coming for the intervention from lateral to medial. Normally we do injection here, and that is where you have to be careful with the vessel. Don't inject inside the vessel. But this is not only one thing. We're looking bicep tendon. You have the subscap here, and you have the coracohumeral ligament here, and superior glenohumeral ligament here. All these structures have been seen. It is always said this is a window to the joint. I'll show you a few more slides. And always remember, look at the deltoid also along with that. Maybe deltoid trophy sometime. See always in two planes, and this is the vertical plane, always long axis. And then what you see, you might find some fluid here. Now this fluid can be a Biceps Teno-Synovitis, or maybe joint fluid. When joint effusion is there, this goes by a side of tendon, as I told you. This is contiguous with the main joint, and this is the fluid which here. But when you have a tenosynovitis, you have the tendon which is looking dirty, unhealthy, swollen, and sometimes with a lot of vascularity there. And you have the fluid which may be dirty sometime because there's a lot of inflammation if there. But when you inject in there and then you give it a response. It may be one way to inject intra-articular is when you inject right at the rotator cuff interval. I'll come to that after a few minutes. This is what you're looking at. The bicep, when you're coming for the injection, you're coming lateral to medial, avoid this vessel, go in there, inject. This is what we normally do. Very good response. We inject steroid if it is inflammatory. We inject PRP if it is one of those degenerative lesions or there's a partial tear. And this is what is important. Now, when you go a little lower down, you see the muscles, long head of biceps and the short head, and then you have the coracobrachialis, which is called a butterfly view. If any one is gone, then you really know there's an injury here, and then one wing is gone or the other wing of the body is gone. And sometimes this is what is called the proximal enthesis failure is there, and you have the injury coming up here, and then you have the Popeye sign, typical. There's a proximal failure of the biceps, long head and short head together, and there's a Popeye sign, typical Popeye sign is there. And this is the kind of going more proximal on the tendon when it rotates and gets into the joint, and that is how it becomes from round, it becomes oblong, and it start rotating, and start getting more flattened because it has to insert over the glenoid superior margin. And then this is the rotator cuff interval. This I told you is a window to the joint, and you see so many things are in there. And now the next slide which tell you, this is it. Then you have the coracohumeral ligament is there. This is the superior glenohumeral ligament, and this subscap is there, and the supraspinatus is there. Remember, this all is a rotator cuff coming in one way or the other. I'll show you more slides on this. And this is it. And this is the information which you're going to get. If there is a failure of the coracohumeral ligament or rotator cuff tear, the tendon will go out there and it will go out. If there is a subscap failure, the tendon will go under the subscap. If there is a rotator cuff failure, the tendon will go over the subscap. So these are things which are there if you know it. So the biceps tendon sometimes is not in its place, so it keeps moving around. That is very important. So you do a dynamic stand and you can see all this. And what all you can say is proximal biceps tendinosis. You can see rotator cuff involvements. You can see biceps subluxation, which I just mentioned. The gravihumeral instability can be there on the movement. You can look for this with the straining. Then adhesive capsulitis, impingement for sure, and bursitis. It's important. Where do you find fluid? You can find fluid even in here. There can be a bursa right from here to here. Look for the bursa. Now what I'm going to talk about the Biceps Teno-Synovitis, this angry red tendon in there. Look at the power Doppler and you look at those things, and this is the dirty tendon. And you treat it, as I mentioned you. Initially steroid and then PRP if it is degenerative or damaged tendon. Yes, I told you joint fluid effusion, this is one of the way the joint effusion shows up. And you can, if you put a drug in here, this will get into the joint and go all over the joint just like a knee. Put anywhere, it goes all over. So that's the important thing to understand. But if, one more important point, if your fluid, if you inject in here, it goes over this biceps in the subacromial subdeltoid bursa, that means there is a interval failure or communicating rotator cuff failure. or complete tear, you can call it. This is about adhesive capsulitis. This is thickened ligaments are there, you can see. And there's a vasculitis also is more. So this is about adhesive capsulitis, more of fibrosing disease, I told you. And the glenohumeral synovitis, you see all over is all red and inflamed, and all of the synovitis is going on, and you see a multiple power Doppler, multiple of these red things. The tendon looks great normal here. Just look at this. Until the secondary gets involved, this is normally a normal tendon. So that way you can really diagnose these diseases right from that small window which is there. The AC joint, you start walking on the clavicle and keep going laterally, suddenly there's a dip here, and that is the AC joint. Very easy, very good, and should be doable. But the only problem is a very, very superficial joint, so there has to be a trick to manage it. And the trick is that you do a gel standoff technique, because you cannot go intervention. You can always see joints, but to put in a needle, it becomes a problem, because when you start putting in a needle, you may pith your probe. So you put a lot of gel in here, and this is gel standoff technique. You can just get in here and put your needle like this. Just have a look at it. This is how you're going to put your needle, with the gel standoff technique. You can save your probe on that, because people have pith their probes with the superficial injections. And this is about the other way of doing it. You can do out of plane. You just look at this out of plane. You look at the joint, another picture. You look at the joint in there and take your needle right in there. One lead I'll tell you in here is your M line on the ultrasound coincides with the middle line here. There's a middle line here. And when you follow the middle line, this will follow the M line there on the ultrasound probe. And you can really dip into the joint and be there. I've done sometime through the same joint, I've done the injection through and through into the glenohumeral joint also if needed, if it is needed. Just few lines, and that's the word is the compression. This is what is impingement, is the compression of the rotator cuff and subacromial subdeltoid bursa by the overlying crocioacromial arch. It's not only the acromion, it's a crocioacromial arch also, which is important. So we always keep talking acromion, and it is important how do we look at the arch. From one side to the other opposite nipple, if you put a probe here, you see crocioacromial arch, and that's where the impingement happens. And you have to look fluid under this. This is important. We should look at the fluid where there is a fluid line. And this is what we're going to look at, the crocioacromial arch. Now when we do dynamic checking, when you abduct the arm, there's an impingement going on here, there's a lag of the muscle here, muscle pulling is going on like a trigger finger. And then you have a fluid which gets collected here, and that is where you can inject. The whole idea is you can inject. This is a large bursa, and you can inject at any place, coming from medial to lateral, lateral to medial, anterior, posterior, posterior to anterior. Because this is a communicating place, and you can really inject. This is what I told about the window. This is a fusion of the joint, and you inject in and get into the joint. This is the window I was talking. And this is about the bursa. If you have, there's a bursitis along with, not only fusion. Normally you see bursa is not visible unless it's inflamed and filled, only then you can see it. Otherwise it's just lying there, just like in lateral trochanteric bursa. So this is how it has been done. You can do from any direction, but go in plane. Very, very important. Any place you go in plane, because you really see tip of your needle and you can put the drug. The whole problem was people have been injecting into the muscle bellies and all steroid. We've been doing all life. I feel guilty of that. And I want everybody to practice ultrasound and do ultrasound way instead of anything blind. Because we've seen most of the time you can put 1/4 or 1/5 of the drug and still is more effective. That's the whole advantage. And after all, it's steroid. And that is how it has been done. In plane, instead of injecting anywhere else. So people have done a mistake. They're putting drug in here in the fat plane, which goes over the acromion. You put a drug under this, in the bursa over the muscle, and just gets into the acromion. That's the typical sign here. The drug is getting under the acromion. This is important. And you can see really going under the acromion here. That's the most ideal. Don't put your drug, steroid, never ever into the muscle. You're going to cause tear, and you're going to increase the tear and pain also for that matter. Yes, for PRP and regenerative and biologics, it is more important to put inside the tear, inside the belly, inside the disease structure. This is very, very important. Another point here is you look at the glenohumeral joint here. These two are different lines. If there is a rotator cuff tear, they will become one. This is important to know. And another thing is there's always a lateral recess. Next picture you see, there's always a lateral recess here. You see lateral recess. If you can find a lateral recess, you can just simply inject in here. It works good. You don't have to get into the trouble zone. This is about supraspinatus. And this is you see in different planes, and this is how we 5 millimeter from biceps, and this is how it looks. Typical beak appearance, a bird beak appearance, and with the foot of this, and then we have more pictures on this, and we keep going posteriorly. This start getting more flattened, the greater trochanter, and you start seeing it's getting more roundish. And if you keep going posterior, you'll start getting the inferior spinatus muscles also for that matter, and you can be just over the infraspinatus. And that is how normally the scan is being done. You put your probe in there and towards the opposite hip, and this is what you see, the sagittal view of the hip, what you see in MRI, and that is what you're going to see. And this is a very, very good view. This is what I was talking. You look at the cross section now, the short axis view of the tendon. See, the problem happens is people see some part of the tendon and they say, yes, it's okay. It's always good to see tendon from anterior to posterior, medial to lateral. Only then you can find small tear, which people normally have been missing, and they are going for MRIs. Otherwise, ultrasound is a very, very good tool, and people getting more perfected, they can find it easy. So this is how you're going to look at the images. You have the biceps tendon in here, most flattened, then supraspinatus, then you have the conjoint tendon coming, and at the back of it, after conjoint tendon, you have the infraspinatus tendon, the teres minor. You can see it all there, and this is what is rotator cuff interval I talked about, the long hairs of biceps. And there is a progressive tear, you can pick that. One of those theory slides, where there is absent tendon, there is a complete rupture. When the swollen, and by the way, this is the roof collapses there. When the complete rupture is there, the roof collapses, and the deltoids gets into the tendon area. So sometimes there is no tendon, only deltoid is coming up till here. This is a swollen hypoic tendon is tendinosis. The linear defects are longitudinal delamination tear. People don't pick it normally until they're expert on this. Irregular enthesis and enthesopathies is known in the all those inflammatory diseases. Then you have the fluid anterior to tendon, which is bursal fluid. The fluid thick bursa anterior to tendon is bursitis. That means there's a bursa inflammation. And there's a long head of biceps anterior to subscap, which I told you, rotator cuff interval failure or the subscap failure. And this is what you look at. The bird beak appearance typical. And the next is there may be partial thickness tear, which could be in the articular place, bursal or intrasubstance failures, or there can be full thickness tear, and you really have to find the distance, how much is the direction which has happened with the failure, and really see where is exactly the tear. The typical tear is a recurrent tear, which is a partial tear of the articular surface, then the partial is the bursal surface tear or full thickness tear, and partial tear intrasubstance tear is there. These are very amenable to PRP therapies and all those regenerative medicines. And don't never ever put steroid in there. Always remember, steroids are always around the tendon, never inside the tendon. And this is the study which has been done with the PRP and tenotomy, and they found PRP is much better than tenotomies. And same way they did a study with the rotator cuff repair. They use stem cell now, and they found stem cells are much better than not putting stem cells in the repair, and with the ultimate results is much better, and not relates with the number of cells they used. And this is a very, very good study which was done. This is about supraspinatus tendinosis. You see swollen tendon, hypoic areas, some tears, vascularities, sometimes calcifications, and you should really know if there is any doubt, compare with the normal side. You always have a control with you. So the other side is a control side. You can always go to the other side and do it. This is about a calcific tendinosis, very typical of this. See X-ray. You do not always find on X-ray, but you can definitely find on the, you see posterior shadowing. You can always find on the ultrasound. And this is very good, responsive to treatment. And what you do is you do multipath, you do wash, and this is how it is done. Give a local. Now after giving local, put a thick bore needle. You can put 2 needles, one for lavage, one for irrigation and all. And then you do multiple punches, and at the end of it put some steroid. And it is said, if you just take those crystals out like this, and make it more dependent, so you can pull it out and put in a LA, because it's painful procedure. Put in a LA and wash it, and even if you pitch it multiple times, it responds and gets absorbed over a period of time. This is about the adhesive capsulitis, which to differentiate from the shoulder pain in the impingement. And this is what you're going to see. This is the rotator cuff interval hyperemia. You see, typical of this, you're going to see this is about the adhesive capsulitis. And this is about the axillary recess. Another important window which people miss very often is go under the axilla and see under the axilla, and there's a thickened ligament there, and this is the inferior glenohumeral ligament, which thickened is a part of the adhesive capsulitis. Very important way to diagnose. Just one or two important points. Impingement in there's only a mid-arc pain, and this is a global movement pain. Adhesive capsulitis, more of acute onset. And in adhesive capsulitis, there's early scapular activation. As soon as you start moving shoulder, the scapula starts activated. And this is the normal scapular activation, which is after 120 degree of abduction. So this is the important point to differentiate between those two. And observation, this is a posterior shoulder, by the way. You see the glenoid, you see the muscle, you see the deltoids, and then you just see the glenohumeral joint, and you start looking at the fusion and labral tears. You can really pick a lot of good things in here. Sometimes there is an impingement. Now, this is a dynamic scan. When you do a dynamic shoulder rotation, you see this is coupling and something like ligament flavum hypertrophy, buckling. This happens here also, and you pick it. Remembering the joint is a single joint in here. Look at this point. This is a recess, axillary recess. You can address from here, you can go from posterior, you can go from anterior, you can go by the side of the biceps tendon. And this is how you can always access the joint, glenohumeral joint. Another important point is you look at the fluid in the axillary recess when you're in external rotation. Normally you put the arm in the medial rotation or the opposite shoulder, but that's not the case for the fusion. You just strain the joint by external rotation, and that is how you get into the joint there. Mostly go from lateral to medial. This is medial to lateral, and you can come from other side also, depending on people are going from here, people going from here. But avoid labrum, avoid the joint capsule. This is very, very important. And put your drug. It should go walking inside with the Doppler on. And this is important slide. This is the
sorry to interrupt, sir.
Yeah.
Sorry to interrupt you, sir. Sir, we already crossed 30 minutes now, sir.
Okay, almost 3 minutes only. We're done. So this is about the suprascapular nerve, and we do a suprascapular because we're going to do pain relief. We are pain guys, and we can do the suprascapular notch. We can do spinal glenoid notch. This is important to remember this joint. If this goes, supraspinatus goes. If this goes, infraspinatus goes. If the axillary block goes, then the teres minor and the deltoid goes. So to just give it a block here, this is the supraclavicular here. This is suprascapular notch, and this is where you put your needle there. And when you scan, you can scan with the linear probe. But when you do a procedure, you always try to do curvilinear because you can see your needle coming. It is deep, it is curved now, so you have to keep that in mind. Another important point is sometimes you can do a out of plane approach. Come from anterior to posterior. If you go posterior to anterior, you can go across and you can injure the other structures. Come from anterior to posterior, again the M line, and then you can just be the this. This is about the pulse RF, and they found a good response. I always do pulse RF along with some amount of dipomedrol and helping the patient. There can be some bad ganglion, is known at the spinal glenoid notch, and you can really aspirate, put in steroid. Just few slides, 1, 2, 3 slides. And this is important. This is the suprascapular nerve, which is the anterior part of it. Now coming from the C5-6, it is going along the suprascapular vessel and a suprascapular vessel, and is going into the notch in there. And this is here you see, this is a brachial plexus, supraclavicular area. This is you seeing the nerve here, and then you just block in there. And this is about the latest find which was there, the neuromodulation. This is peripheral nerve stimulations. You can put in there. It gives a good response in adhesive capsulitis, chronic knee shoulder pain, and a very, very good response. It is already approved with the FDA, and a very good response. The last 2 slides. This is the quadrilateral syndrome where the 2 muscles are gone and there's a axial neuralgia. But very important for shoulder pain is important to block the axillary nerve also. Otherwise pain stays. The dermatome, always remember, you should differentiate from C5. There can be cervical involvement. So C5 dermatome goes like this, and the axillary nerve goes like a police badge sign. And then the other is biceps involved. Biceps is not involved in here. And this is how we go in there. The needle goes in. Always look at the vessel by the side of it in the quadrilateral space and the quadrangular space. And this is where you see the vessel. Next to the vessel lies a nerve. And you put your stimulator. Now, this is a peripheral nerve stimulator. Is a very, very good thing where they put a stick-on devices are there which stimulates the nerve and takes the pain off. It's very, very useful. Thank you so much, my friends. And thanks for bearing with me. Thank you. I'm open to questions. If there are any questions, let me know.
Thank you, sir. Thank you. Wonderful. As usual, there is nothing to say. You are always, wonderful. Sir,